Hey everybody, welcome to the webinar. It is the 24th of April 2020. It is 11 a.m. And we're all set. All right. First things first, let me share a big thank you to each and everyone who is here on time. We see more than 600 delegates already present at 11 a.m. I know time schedules have changed, including mine, because I have almost started living in a different time zone. I have no clue of when the sun rises and when does it finally go down again. My day and night schedules have changed. Right, but firstly, let me thank all of you all for coming in. Secondly, let me thank the platform of Dental Reach for having done such a wonderful job with getting the entire webinar together. The platform that I'm using is a new one, but I really like the look and feel of it, and I hope you enjoy the session with me today. A big thank you to Dr. Samuel, to Dr. Nupur, who are the people in charge of getting this event together. All right, so as promised, we shall start off with the session. I'm going to start sharing my screen with all of you all. You would still be able to see me. If you have questions, please put them down in the comments section. The plan is to complete the entire webinar in one go so that we do not have any breaks or continuity loss. Once the entire webinar is over, we plan on dedicating at least a 30-minute session because I am absolutely certain there will be a lot of questions. And I have one belief for those who've attended my courses in the past, they would know I want to make sure that when you go out of this webinar, you have answers to questions and not more questions. All right. Full mouth rehabilitation is a complex topic. The time is limited. Having said that, I'm going to try to put in as much as possible within the stipulated time frame and do justice to the fact that you have wasted your time, efforts, and energy into logging in and hearing this webinar today. So here it goes, friends. I'm going to start off with my screen share. All right, I hope my screen is visible to everyone. Perfect. Okay. A fantastic thing also that is associated with this webinar, friends, is the fact that at the end of the webinar, you can log on to MIK Dental. Sorry, did I lose my screen there? I might have. Okay, I'm sorry about that. I've lost my screen, haven't I? Okay, I'm going to go back, open that again. Okay, here goes. Perfect. Okay. And I may have lost it again. Sorry about that. A few glitches in the beginning are only good ones for everything to go well later. Sharing screen, share, and I am live again. Okay. All right, friends. So what I was telling you is at the end of the webinar, you can go into the website link that is mentioned there. The website link will be shared with you in the comment section. There you can go in and enjoy a PDF that has been designed specifically from slides that are very clinically relevant. So you would be able to relive the entire presentation and follow it in your practical dental practice once we resume duties. But remember, there is still time for us to get in and start off with our practices. Let me start off with saying, हम सबका ये हाल है. मुझे भी clinic जाना है. We have been away from what we love doing for a substantial period of time. But friends, at this time when the country and the world is suffering, let us avoid the urge of running back into the practice and starting off with full-fledged dentistry. Right on this platform, I wish to start off with a new campaign, and I would really love if you guys can add in and support me in this campaign, a campaign that I would love to title, friends, No ARTICULATOR, No Aerosol. Your support is going to go a long way in making sure that the dental community and all of us feel that we are in this together. It is very famously said that saliva is the colorless carrier of corona. And it's so applicable to our field of work, right? Because everything that we do involves saliva and the possibility of aerosol contamination, which means we as a profession, our families, our loved ones are at the biggest risk. So let us pledge that we shall avoid the urge, the temptation of running back into practice and starting full-fledged dentistry. I once again, before I start out with my webinar, invite you to please support the campaign, No ARTICULATOR, No Aerosol. All right, friends. So with that, we enter into our topic of full mouth reconstruction. It is titled My Secrets. And in here, I will be addressing 5 secrets. Now, I am going to start with putting in all of these secrets and then taking each of them individually. The first secret is use the correct articulator. Which articulator we shall address in due course of time. Make sure that you do your full mouth reconstructions only and only in one joint position, and that is centric relation. When doing full mouth reconstructions, stop thinking about only posterior teeth. Start concentrating on the anterior guidance, because in time I will tell you how important that anterior guidance is from the perspective of making sure that your full mouth reconstructions survive and they don't start fracturing porcelain, especially on your posterior teeth. The fourth secret is to make sure that you get the posterior occlusion right. As important as anterior guidance is, it's equally important that your posterior teeth do not interfere with the anterior guidance. So very briefly, I will also explain the concept of mutually protected occlusion, and more importantly, what kind of guidances should you be giving your patients when doing full mouth reconstructions. And last but not the least, let's start thinking conservative. I know it's very common, a tendency for clinicians who are doing full mouth reconstructions to first endodontically treat all teeth and then go ahead and do full coverage crowns. The problems here is there is no safety factor involved, because if something were to go wrong with your reconstruction, usually this manifests in the form of abutment tooth fractures, and that is a devastating failure. My last point for this webinar will be, let's start thinking about partial bonded restorations. But before we go there, let's go through the journey and start off with the correct use of a semi-adjustable articulator. Now remember, friends, a full mouth reconstruction is a marathon. It is a long bone process. It is a lot of effort. All right. Remember, it's a multi-appointment procedure. And when you are doing multiple appointments, at each appointment, the possibility of things going wrong increase. Now, in a marathon, your footwear matters. I would never want to run a marathon in that. Not that I would ever want to wear that, as elegant as it looks. But for a functional purpose, I need something that is going to allow me to function in a comfortable and a relaxed, predictable manner. So using a semi-adjustable articulator is the first protocol. Now, why do I insist on a semi-adjustable articulator? It is because we as human beings do not do hinge movement, which is unfortunately what most of our articulators do. We function, friends, in what is called as a dynamic movement of the mandible. And have a look at this here. This is dynamic movement of the mandible, which involves a side-to-side movement in an attempt to masticate food. Whilst we're doing side-to-side movement, we also do front-to-back movement. Now, why do we do this front-to-back movement? Because we want to incise food. All of these movements involve translation of the condyles out of the glenoid fossa. Now, look here. This is just a representation of what a semi-adjustable articulator looks like. Let's look at the back end, which I have highlighted in blue color. All right. If you look at the pink portion, this is your glenoid fossa. If you look at the fluorescent green, this is your articular eminence. Look at where the head of the condyle is. The head of the condyle is currently in the glenoid fossa. I say the head of the condyle is at home. वो घर पे है. It's very comfortable in that position. A semi-adjustable articulator, friends, is designed a similar basis as human anatomy. So now remember reading Christensen's phenomenon. When you protrude your jaw forward, there is separation of the back teeth. Okay. Now here on the articulator, this represents H value. H value. This is called as the horizontal condylar guidance angle, which is nothing but the angle of the articular eminence. On the articulator, as well as in the patient's mouth, when we translate the jaw forward, recognize the fact that there is separation of the back teeth. Now, I want all of you all to recognize the amount of separation there is. There is a sizable amount of separation present. I go back into maximum intercuspation, I go back into centric relation. Now look closely. Everything else remains the same. I only change one thing. I decrease the H value. So look at the yellow portion. I have only flattened the condylar guidance, which means, let's say, for example, the condylar guidance went from an angle 45 to an angle 25. Does this happen? Yes, it happens. Now remember, a bruxer is someone who does parafunction in the horizontal dimension. Okay. Now each time the patient parafunctions, the condyle also is moving in and out of the glenoid fossa. When this happens way too frequently, there is excessive friction inside the capsular structures. Now what happens? Remodeling of structures. Remodeling in the form of flattening of the condylar head, as well as flattening of the slope of the glenoid fossa, which simply means that the H value of the patient has decreased. Now, what happens when the H value decreases? Look closely. A patient with a lesser H value, when he or she protrudes forward, look at the amount of space that has opened up at the back. Remember, when the H value was more, the space that opened up was greater. When the H value is less, the amount of space that has opened up is actually less. Can I safely say H value determines the amount of posterior separation during protrusion? How does this impact my full mouth reconstruction? It helps me and my technician decide what will be the anatomy of the posterior teeth. Imagine a patient comes to you with a very good H value. When I say a very good H value, anything that's above a 35 degrees is very good. Because when a patient comes with a very good H value, remember, each time the patient protrudes forward, there will be separation at the back. Because there is good separation at the back, I can simply tell my technician, give my patient very, very good cuspal anatomy, nice, tall, sharp cusps, so that I can increase the masticatory efficiency of my patient. On the other hand, if a patient comes to me with a smaller H value, let's say, for example, my patient came to me with an H value of 25. This patient, when he or she protrudes forward, the amount of separation at the back will be less. Now, what will happen? If I or my technician land up giving this patient very tall, sharp, beautiful cusps, as soon as the patient goes in protrusion, ceramic at the back will keep touching ceramic. There will be interferences, and this will increase the possibility of ceramic fracture at the back. Now remember, when we sit and adjust occlusion, we only check static. Unfortunately, we do not always check dynamic mandibular movements, and that is where porcelain fractures at the back. That is how important H value is. Setting the horizontal condylar guidance on the articulator is a very important step towards a successful reconstruction. And that's where a semi-adjustable articulator comes in. Because friends, a semi-adjustable articulator, as you can see at the back, has numerical values written there. 0 going up to 60. Each stroke is about a 5-degree change in the angle, which means I can customize the horizontal condylar guidance of the patient on the semi-adjustable articulator. H value is frequently termed as the posterior determinant of occlusion. And you know what the best part about H value is? There is absolutely no compulsion that the H value on the right side will be the same as the H value on the left side. Both these joints may be interconnected, but remember, they still retain their individuality. Imagine a patient who tends to bite more on one side. That patient cannot have H value on both sides that are the same. Imagine patients who walk into your practice, one side is more attrited, the other side is not as badly attrited. Again, this is an interplay of the horizontal condylar guidance angle. Okay. This area is the important area on a semi-adjustable articulator where I customize the H value. Now I know there's a question in your minds. Okay, I've understood H value is important. Now how do I record the H value? The simplest way to record an H value is to have the patient bite in an edge to edge position and then record the amount of separation at the back with the help of a bite registration wax. This is your alu wax. I love to use Bital. I will show you what Bital is as we move forward through this presentation. Okay, now it is not possible in such a short webinar for me to explain the entire video and the process of the H value, but if you are keen on understanding that, I will urge you to go on to YouTube, log on to my channel, subscribe to it, and watch a video which is titled Programming the Articulator. This will help you understand how I use the protrusive bite to set the H value on a semi-adjustable articulator. The articulator that I prefer to use in my practice and during my courses comes from a company named Corrident. It is nothing but a copy of a famous dinar articulator, just that Corrident gives it to us cheaper. All right, CSA 400, CSA 400. That's the model that I prefer to use. Again, if you log on to YouTube, you will see a video where I've differentiated different models from the company and helped you understand why is it that I prefer the 400 version, which is easier to use, simpler, and more importantly, a lot more economical. Now remember, in difficult times with economic crisis, this aspect will definitely become important to all of us. So log on and enjoy the video. Now, semi-adjustable articulators have one more added advantage. It allows me to record a Facebow. Now, why is a Facebow important? Because a Facebow firstly gives me the angle of the maxilla. Now, remember, maxilla could be superficially based, it could be inferiorly based, depending on the length of the face, long face, short face, broad face, narrow face. How often do we see maxillas that are a little canted off? All right, so it gives me the cant. It tells me how far forward or backward is the maxilla placed. Class 1 maxilla, class 2 maxilla, class 3 maxilla. Because remember, unless you have a stable maxillary relation, there's no ways you'll be able to relate the mandibular cast correctly. So maxilla is fixed to the cranial base. So we use a Facebow to give the orientation of the maxilla on a semi-adjustable articulator. What it also gives me is the distance from the condylar head right up to the maxillary incisal edge. Now, why is this important? Because this determines what is called as the arc of mandibular opening. This becomes important in any case that you change the vertical dimension, which is almost every case of full mouth reconstruction, right? Which means when you are working on a full mouth rehabilitation case, a Facebow record and a semi-adjustable articulator are compulsory. Again, log on to YouTube and watch a video which is titled Facebow Patient Demo, which will give you the entire step-by-step protocol of how to record a Facebow in less than 2 minutes. The procedure is very, very, very simple. It's just in our heads that we feel semi-adjustable articulators are difficult and they are only for prosthodontists. When I went through the process of learning it is when I realized it's all up here. It is very, very, very easy to understand and very easy to implement once you understand the basic concepts. So log on to YouTube and enjoy these videos, because semi-adjustable articulators are the first criteria for making full mouth reconstructions successful. Please do not fall prey to doing these on a 2-point articulator. Even mean value articulators do not serve the correct purpose because there is no Facebow transfer and you cannot customize the condylar guidance. So my strongest suggestion, start by using the correct articulator. Moving forward, why is there the excessive impulsive discussion on working in centric relation? Look here, I have a patient who's biting into food. I have done a lower right molar preparation. The moment this patient bites into food, elevator muscles become active and the depressor muscle, which is the positioner muscle, also called as famously the inferior lateral pterygoid muscle, is relaxed. Remember, elevation activity means elevators are active, depressor is inactive. But if I were to put a crown into this patient's mouth, a crown that is fitting high, and I tell my patient, don't worry, give it 2 days, your crown will settle. These words will create havoc in your patient's mouth. Why? Because remember, with 1 point of contact, your patient is not going to be able to bite. So what does the patient start doing? Over the next 2 days, the patient starts clenching on that point of contact. It's called as a hit. As soon as the mandible hits it, the patient starts clenching further and the mandible physically slides forward. Hit and slide occlusion. Mandible comes into a new MIP, that is a new maximum intercuspal position. And in order to do that, remember, the entire condyle has to come out of the glenoid fossa, which means if you put an interference into the patient's mouth, or if the patient has a third molar that is causing an interference, MIP does not coincide with CR, which means each time the patient has to close into maximum intercuspal position, the condyle has to be pulled out of the glenoid fossa. Which muscle does that? The inferior lateral pterygoid muscle, which has now gone into a spasmodic contraction. This is commonly referred to as incoordinated muscle hyperactivity. It is as if your muscles are doing overtime. No wonder these patients complain of joint pain. They complain of masseter muscle pain. They complain of tension headaches because all of these muscles start undergoing hyperactivity. This happens in MIP. The key is to understand that in MIP, there is instability. MIP is commonly called as orthodontic stability, orthopedic, or condylar instability. And when instability steps in, the weakest link in the entire chain gives way. Commonly, the weakest link is the tooth, which is the reason why often in a patient who has an interference, we will see atresion, we see abfractions, we see teeth fracturing, we see cusp fracturing, we see porcelain fracturing, we see antagonist teeth fracturing. We even have patients who come in with sensitivity that does not seem to go with regular toothpastes. If the periodontium or the gingiva, on the other hand, is the weakest link, this patient commonly has mobility. The tooth becomes mobile. There's periodontal widening. Often, secondary trauma from occlusion will lead your patient with bone loss. Now you have food lodgement that has started interdentally, and eventually your anterior teeth start moving forward, the commonly called pathologic migration. Remember Fremitus test? All of that is pointing to instability in the system. If the muscles were to receive the brunt of the interference, this is a patient who complains of soreness in the muscles. Upon opening, the mandible starts deviating in different directions. Some of these patients can't even open mouth. It's like a trismus-like situation. The worst amongst all of this is, friends, if the temporomandibular joint starts getting affected, because this is a patient who starts developing clicking in the joints, pain from retrodiscal compression, and dysfunction. All of this because the patient has one possible interference. And now, why is this so very important in the current COVID era? Because these interferences require the presence of stress to create a problem. Now, aren't we all in a stressful situation? Physical stress, mental stress, emotional stress, financial stress, social stress, religious stress. Given the amount of stresses in the lives of our patients, be rest for sure there will be more and more and more patients in due course of time who will come to you needing reconstructions. This is no longer about aesthetic dentistry where I want to improve my smile because I have money. No. This is now I need a reconstruction, and although I don't have as much money, I am left with no choice but to start collecting money so that I can get myself treated. Be rest for sure, on an immediate basis, you may not find full mouth reconstruction patients, but as we move forward, the number of patients needing reconstructions is only going to rise. I am certain midlife crisis is no longer at 40, but it's coming down to an age of 30. More and more younger patients will need full mouth reconstructions. They are waiting for people who are in a position to give them the service that they deserve and they desire. So learning full mouth reconstructions today is very important, not for immediate implementation, but in times to come. Post-COVID era, be rest for sure, patients are waiting for reconstructions. All right, let's come back. Too much philosophy. Okay, let's come back to dentistry. Let me first introduce to you what is called as hit and slide occlusion. As the individual closes, the first point of tooth contact, as you see on screen right now, is called RCP, retruded contact position. This is where the condyles are in the glenoid fossa. This is where the patient starts closing when there is a first high point. As the patient clenches forward, the entire mandible slides into MIT. This is hit and slide occlusion. Remember, for a slide, condyle has to be pulled out of the glenoid fossa. Now, hit and slide occlusion is normal. It is 90% of the human population has a hit and slide occlusion, but it is not easily manifested. Why? Because the brain is a beautiful organ that protects the system. Giving you a simple example. Imagine you're going down a fast road one fine day and your car suddenly goes into a hole and you bump that hole. What has your brain done? Your brain has subconsciously registered that you bumped into that hole. So next day when you go through that road, be rest for sure, as you approach that bump, your brain will tell you, let's move around, let's slow down. Let's not hit the bump again. That's exactly what happens to the mandible. Hit and slide, hit and slide, hit and slide. Subconsciously, your brain understands there is an interference. So what does the brain do? The brain tells the lateral pterygoid muscle, avoid the interference. So the lateral pterygoid muscle starts closing the mandible in a different arc of mandibular closure. Over 2 days, occlusion has settled. Remember, this settling is never physiologic because it involves muscle hyperactivity. And a very famous saying, when tooth goes in war with muscle, muscle never loses, which means that interference tooth and other teeth will pay the brunt for this interference the time this patient goes into a stressful situation. Also remember, different individuals respond differently to stress. Human thresholds are very, very varied. Some people respond very well. Some people succumb to the smallest of interference. So let's avoid putting in interference. In a full mouth reconstruction, it is very important that we trick the brain. Why? Because the brain takes the patient directly into MIP and avoids the interference. It is very important that we trick the brain into believing that there is no interference. That's the only way, friends, and I repeat myself, that's the only way you can relax the lateral pterygoid muscle. Lateral pterygoid muscle will always stay in spasm if there is an interference in the mouth. The moment you trick the brain into believing there is no interference, the lateral pterygoid muscle begins to ease its contraction and begins to relax. And what happens as the lateral pterygoid relaxes? The condyle goes back into its centric relation position. This is where the concept of deprogramming the mandible steps in. Friends, the concept of deprogramming the mandible is nothing but creating separation between posterior teeth. Because remember, most interferences are on posterior teeth and the mandible slides into an anterior direction when we talk about a hit and slide occlusion. So how do you deprogram? How do you separate posterior teeth? It is with the help of an anterior deprogrammer, often called as a Lucia jig. What does an anterior deprogrammer do? Look, it has separated that interference tooth at the back. Usually this is the second molar or a crown on the sixth, or very commonly this is a third molar that has come mesioangular in terms of its position. These create interferences in life over a period of time. With stress, it causes instability. The moment you separate the back teeth, sometimes minutes, sometimes hours, sometimes days, it takes for the lateral pterygoid muscle to completely deprogram itself. This is the concept of short-term, intermediate, and long-term deprogrammation. Again, log on to YouTube and search my videos on centric relation. I have recently uploaded 4 webinars that describe in detail the concept of deprogramming the mandible. In here, showing you a very brief understanding of the same. I, in my practice, do this with the help of Unwind MD. It is a prefabricated anterior deprogrammer that I have designed myself. Its function, like any other deprogrammer on earth, is to separate the back teeth. Very quickly, let's look at how it functions. Just giving you a diagrammatic understanding here. This is classically how a bruxer presents to you. Back teeth are treated, front teeth are treated. More importantly, look at front teeth. The front teeth are in an edge-to-edge position. Why are they in an edge-to-edge position? Because the mandible has come forward. As soon as you deprogram, the mandible goes back. And as it goes back, the edge-to-edge position once again becomes a class 1. This is very similar to, remember reading a pseudo class 3? The anteriors go into a cross-bite relation because there is an interference. Bruxers who come edge-to-edge almost always are in a forward position. So how do we take them into correct CR? We ask them to open their mouth. We now put in the Unwind MD. This is the anatomic position in which Unwind MD goes in. The longer face is labial, the shorter face is towards the palatal, and the upper 2 central incisors go and fit in. I now reline this with either a bite registration paste, or very frequently in my practice, I do this with cold cure acrylic, the clear powder liquid that we have. The same is relined and placed into the patient's mouth. It can be removed by the patient. Okay. Now, what is the patient supposed to do? On the basis of short, medium, and long-term deprogrammation, the patient is supposed to wear this for a few hours a few days or sometimes a few months. As the patient bites down into this, all right, remember back teeth don't touch, only front teeth touch. Because back teeth don't touch, the inferior lateral pterygoid muscle relaxes. So what happens over a period of time? The entire mandible begins to swing backwards. Remember, the condyle goes upwards. As the condyle goes upwards, the lower incisor comes back. Now look at the anterior relation. It's become like a anterior class 1 incisor relation. At this very relation, I go ahead and I record the centric relation with the help of the block of aluminum reinforced wax, that is Vital. Very quickly showing you an example. This is one of my patients where we did a reconstruction. Look here. We relined the unwind with the help of imprint bite. This is a bite registration paste that is from 3M. Look closely as to where is the lower incisor touching right now. The lower incisor is touching the deprogrammer at the black mark that I have made there. It's a marker that I use to just point out the position in which the lower incisor is contacting today. I now have the patient wear this overnight. When the patient comes to me the next morning, look closely at what has happened to the mandible. The entire mandible has swung in a backward direction. The lower incisors are now contacting the deprogrammer at the centric relation mark. I now make one more mark with the pen, and it is at this position I go ahead and record the centric relation bite. This deprogrammer, friends, is available on mikdental.in, which is also where you will find the PDF of this webinar. For recording the CR, I use Vital, which is a block of wax. It's the first of its kind. Normally we get wafers, we get thin sheets that we are supposed to stack on top of each other. But here is a block of wax which is homogeneous. So you soften the wax and you go ahead and register the bite with the deprogrammer in the mouth. All right, now the key here is no centric relation record can ever be perforated. Perforation means tooth is contacting tooth. Remember, tooth contacting tooth means lateral pterygoid is active. You have lost centric relation, which means you have to always record the CR at an increased vertical dimension. Once again, all CR records are recorded at an increased vertical dimension. That does not mean it's the final VD. The final VD is determined on the articulator, and I will help you understand that as we move forward. At this point, let us recognize that CR is recorded with the unwind in the mouth and with the help of a block of aluminum reinforced wax. At this point of time, I don't like to use bite registration paste. Why? Because those are two pieces only. And when mounting, it's very difficult to get those two pieces to fit perfectly. However, when I have a block that's crossing the palate, remember, I am getting cross arch stabilization. So mounting the casts with a bite record, which is made like this, is extremely easy and, more importantly, far more accurate. So I would strongly suggest use unwind, use Vital to register your centric relation bite records. When doing this, please always use a wide view cheek retractor. Again, this is Penora view, something that I have designed. It makes sure that you take your elevator muscles away so that your patient does not close towards the sides. Isn't it common when you put bite record on one side, tell the patient close, the patient takes the entire mandible towards that side? We don't want that to happen. That is where a wide view retractor, Penora view, which has a progressive retraction component that I have designed into it, takes the muscles away and allows the patient to bite only in the center. I will never record my bite without the Penora view in. All right. Now coming to why is there so much importance given to centric relation? Because centric relation, friends, is comfortable to the patient. It is repeatable by the patient. It is recordable by us as dentists. What do we do in complete dentures? We first record CR. and then we arrange the teeth in CR so that MIP and CR coincide with each other. That's exactly what we need to do in tooth supported full mouths. We record CR, but instead of setting acrylic teeth in, we do a wax up. A wax up which makes MIP the same as CR. So the concept does not change. But remember, in complete denture patients, you don't have to do deprogramming because there is no proprioception. In the natural dentition, because you have proprioceptors that are present in PDL, deprogramming becomes a mandatory step. You cannot work in MIP. You cannot tell the patient swallow and close like you do in complete dentures and record a bite. That is not enough. Deprogramming for minutes, hours, days, or months is very, very important. So here, once again, I strongly urge you, once the video is done, whenever you find time, please log into YouTube, subscribe to the channel, and watch the videos on centric relation. It will completely change your concepts of deprogramming the mandible. Further, why centric relation? Because centric relation, friends, is the only position, and I repeat again, the only position that will give me interference-free occlusion. And it is an interference-free occlusion that gives me peaceful neuromusculature, the lateral pterygoid. For students who've attended my courses, they know how important lateral pterygoid is to me. It's so important, I call it the mother of the joint, the mama. It's the one that's protecting the entire system. We want it to be completely relaxed when we do full mouth reconstructions. And last but not the least, and this may come as a surprise to a lot of people, CR helps me determine the vertical dimension. So let me tell you here, I do not determine VD in the patient's mouth. Determining VD on the basis of freeway space is very flawed. It's a faulty technique. Remember, freeway space is never constant. You can't come in and tell the patient, say mango, say M, and then check for freeway space. And if you find 5 millimeters of freeway space, you tell yourself you can increase 3 millimeters. Friends, that is not correct. Freeway space is dependent on stresses. If your patient is relaxed, you will have a lot of freeway space. If your patient is stressed, is clenching or grinding, the freeway space decreases. If something that is not constant is used to determine VD, you will end up in a problem. I am not saying freeway space is not important. I am saying freeway space is not a determinant for vertical dimension in the natural dentition. Again, it works fine for complete dentures because there are no interferences. Natural dentition, things are different. How do I determine vertical dimension on the basis of centric relation? Quickly. Look here, this is a patient who's in MIP. You can see all the teeth are clenched together, but look at the condyle. The condyle, friends, is out of the glenoid fossa. This means this patient is in MIP and MIP does not coincide with centric relation. Look at anterior teeth, they are edge to edge. What happens when I give this patient an unwind and I tell this patient to wear it for a few hours and come back? Deprogramming of the mandible will occur. When you deprogram the mandible, what does the condyle do? The condyle goes up. And as the condyle goes up, the lower incisor comes downward and backward, which means lower incisor moves horizontally and vertically backward and downward. So look closely at this animation. Currently, teeth are in MIP and the condyle is out of the fossa. As I deprogram, the condyle goes up into CR and the entire mandible swings downward and backward and once again goes and contacts that interference point. This interference point is RCP. Look at the lower anteriors. Lower anteriors have gone backward and downward. So incisal edge relationship is no longer edge to edge. It's become class 1. More importantly, friends, can you see there's automatically space that is available in the anteriors for me to build teeth into? My technician can easily do a wax up here without opening the bite. Try and understand, we're talking about reconstructing the entire dentition without increasing the vertical dimension, which means we are not encroaching into the patient's freeway space. So freeway space will still be present. All we've done is we've deprogrammed the mandible and nature automatically provides me with the space that I desire in a lot of my cases. Once again, you log on to YouTube and watch my video on centric relation and determining vertical dimension on the articulator, and you will get more knowledge about this particular aspect that I have just touched. Deprogramming and working in CR, friends, I cannot emphasize on its importance when doing full mouth reconstructions. Look here. I have a patient who's a Bruxer classic attrition edge-to-edge bite. In MIP, what happens when I deprogram? I deprogram, and can you see the mandible has gone back in the anteriors? There is a space. Look at the sides. This is no longer an edge-to-edge position. Lower incisors have gone into a class 1 relation. Now, why is this important to me? Because my technician can now do a wax up without me opening the bite. My technician can once again give me the correct anterior guidance, because working in CR takes me to the third concept or third secret, which is concentrate on anterior guidance. What is anterior guidance? Remember, along with anterior teeth, you have posterior teeth. Now, as you slide your jaw forward, lower teeth move along the palatal inclines of the upper anteriors, and this is nothing but your anterior guidance. Anterior guidance is important to bring about posterior separation. We earlier discussed condylar guidance helps bring about posterior separation. Now I'm telling you, anterior guidance also helps bring about posterior separation. This is called as the posterior determinant of occlusion. This is called as the anterior determinant of occlusion. Imagine someone who has a deep bite. They will have a lot of separation at the back when they protrude forward. Imagine someone who has an anterior open bite. They will have no separation. Imagine a Bruxer who comes to you edge to edge. A Bruxer who comes to you edge to edge has no anterior guidance. The condylar guidance is flat. So what happens each time they are doing these bruxing movements? All the teeth are contacting together. There's so much friction. There's so much adhesion that is happening. How do I treat this patient? The key here is concentrating on reattaining anterior over bite, anterior over lap. Simply get back your anterior guidance. This is how I want to end my full mouth reconstruction. The moment there is an anterior overbite, as soon as this patient now begins to protrude forward, remember the upper anterior teeth will not allow the lower incisors to go forward. They will take the lower incisors down, and as the lower incisors go down, automatically posterior teeth also disocclude. What happens when posterior teeth disocclude? In the natural dentition, no more attrition. In a full mouth reconstruction, no more porcelain fracture in excursive movements. See how important that anterior guidance is? Stop thinking posterior teeth. Concentrate on anterior teeth, because those anterior teeth are going to protect the posterior tooth anatomy. So remember, concentration on anterior teeth is the third secret that I want to share with you. The fourth one, of course, is get your occlusion correct. Here, very important, please concentrate on two aspects. First is static occlusion, which is in centric. Second is dynamic occlusion, which is in excursion. And for this, I strongly urge you to use a thin articulating paper. Anywhere going from an 8 micron up to 40 microns. 8 microns up to 40 microns. I prefer to use Bausch ARTICULATOR. It's a 40 micron paper, and I love to use this in a horseshoe shape. Now, what is the importance of a horseshoe shape? I can mark all teeth simultaneously. I don't have to put a piece of paper here, put a piece of paper here, put a piece of paper here. It's difficult. You put a piece of paper here, patient will bite here. Put a piece of paper here, patient will bite here. You want to see the occlusion, bang, 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 in one static position. So a horseshoe paper is very important. Remember, do this with the Penora view in. All right, that is the key to getting good centric occlusion. These are ideal points of contact for a class 1 molar relation. The points that I'm showing here are if I may say, an oversimplified picture. Remember, occlusion is never this simple, but the closer you reach this, the better it is. It is as simple as when you put articulating paper in and you have the patient to tap, tap, tap. You see a lot of marks, you remove all of them, excepting for these. You want anterior contacts, you want premolar contacts, you want molar contacts. All of these teeth should contact. Anteriors, 1 contact is enough. Premolars, ideally 2 contacts, enough. Molars, ideal 4, acceptable 3 points. Even if you get 2 points on a molar, kahi baar chalta hai. Don't stress, because do not land up changing the anatomy too significantly only so that you can get those point marks. It's not warranted. Get 2 points on every tooth, posterior tooth, and you're still comfortably placed. These are typically functional cusp tips and maxillary mesial marginal ridges. When you go to mandibular, the scheme is very similar. It's just that functional cusp tip contacts goes to buccal, and instead of mesial marginal ridge, you may get distal marginal ridge. All right, so try to achieve this occlusion in your crowns and bridges, in your full mouth reconstructions, tooth supported, and you will enjoy good success. Remember, please don't follow this for implant supported. Implant supported occlusion is very, very different. Someday, I am hopeful during the lockdown, I shall come in and share my views on implant occlusion as well. But for now, remember, the current occlusal scheme is ideal for tooth supported reconstructions. All right. That was static. Now, what is important is dynamic. What you do in dynamic is you put your horseshoe paper, tell the patient bite down, clench down, and then slide the entire jaw forward. When the patient clenches forward, I ideally want to see lines on all 4 incisors. Now, these should be continuous lines. There should be no break. If there's a break in the line, it means some tooth at the back is interfering. So you'll have to come in and adjust that. All right, so protrusive guidance is ideal on 4 incisors. If you're not getting it on all 4 incisors, do not stress. As long as you're getting it on 2 centrals, that is enough. If you're getting it on only 1 central incisor, that is a problem, because this tooth will start migrating away. All right, this tooth will become periodontally compromised because it is getting over stressed. This is in protrusion. When you go into a right lateral position, the ideal occlusal scheme looks like this. It's called canine guided occlusion. The canine alone on that side is guiding the entire occlusion. Now, what if the canine is missing? What if the canine is a pontic? What if the canine is an implant? What if the canine is a little mobile? What if the canine is a post and core? If you leave all stresses now only on the canine, that canine will fracture or the canine will become excessively mobile. What do you do in such a situation? Even in a full mouth reconstruction, you may go ahead and give this patient what is called as group function occlusion, which means a group of teeth together guide the occlusion. My strongest advice here would be restrict the guidance only and only up till the 2nd premolar. Please do not include a molar into your guidance because it just stresses the system very heavily. Remember, the further behind we go, the more is the bite force, and we do not want excessive bite forces on our porcelain in a lateral excursive movement. Remember, porcelain is very weak in tensile load. So if there is heavy forces going side to side, in natural teeth, you get abfractions. In reconstruction cases, you will get porcelain fractures, or the abutment tooth may completely fracture. So please leave your guidance maximum up to the 2nd premolar tooth. This is static occlusion. This is dynamic occlusion. The best occlusal scheme, as I mentioned, for the natural dentition is called MPO, mutually protected occlusion. Mutually protected occlusion looks like this. Dots at the back, lines in the front. What are dots at the back? Dots at the back, friends, are your static occlusal contacts. Lines in the front are your guidances or your guidance inclines. What happens if you get a line at the back? A line at the back is classically an interference. You are supposed to remove that out. All right, so that's for the maxillary, that's for the mandibular. The concept is the same. Dots at the back, lines in the front. This is the ideal occlusal scheme for a full mouth reconstruction. Now, very important. Get the occlusion right on your provisional restorations. If you get it right on your provisionals, doing it in the final is a copy-paste, absolute copy-paste with the CAD-CAM technology that we have at our disposal today. The difficulty comes in at the temporization phase. This is where your clinical skills come in. So try your level best to do complete justice to the bite. What have I done here? Mounted the casts in centric relation. The technician has done an additive wax up, which means the technician is not allowed to take a burr and trim the tooth. Remember, we are reconstructing, so we only add wax where attrition has occurred, which means nature has already taken tooth material away. So now what do? I made a putty index out of this. Into this putty index, I put a ProTemp 4 type material. It's a bisacral material. Any company works. I love ProTemp 4. It's from 3M. After I'm done with all my preparations, I put this into my patient's mouth. I allow this to set. Now I go ahead and I adjust the occlusion. All right, this is my set of temporaries that have been made. I prefer to keep them joined together whenever possible. If I have teeth that have parallel preparations, I will be able to keep all my temporaries in one piece. That's how it looks. I've taken a 40 micron articulating paper. I've put it into the patient's mouth, horseshoe shape. I've reclined the chair. Now this is important, friends. Reclining the chair is key to centric relation, because as I recline the chair, mandible is pulled back because of gravity. Never should you check CR in a seated position. Complete denture ho, ya full mouth reconstruction ho, tooth supported ho, implant supported ho. Remember, all CR records always in a reclined chair position. Look here, I have beautiful static contacts on all teeth, and as you can clearly see, I have not had to do a lot of adjustment. Why? Because the hard work was done during the mounting phase. The technician did a good job of doing a wax up. I did a good job of transferring the wax up into the patient's mouth. That is maxillary, that is mandibular. Remember, this is static. This is your guidances. Look at the two centrals. The centrals are giving me straight lines. That's my protrusive guidance. Look at the left lateral. It's giving me a straight line. Fantastic. Look at the right lateral. Right lateral is not giving me a line protrusion. No problem at all. Do not worry. Right? Look at those canines. The canines are providing canine guided occlusion. This is how it looks for the mandibular arch. Dots at the back, lines in the front. Look at this. Protrusive guidance, there is posterior disocclusion. When I have my patient go into a left lateral movement, there is posterior disocclusion. I tell the patient to go into a right lateral movement, there is posterior disocclusion. So these are my full arch functional provisionals. Look at them. Dots at the back in blue, lines in the front in red, which means on provisionals, I have achieved mutually protected occlusion. My hard work is done, because now when I make alginate impressions of these and I send them to the laboratory, the technician can make putty indices or use CAD-CAM technology and copy the exact same anatomy into the final restorations. When they all come back to me, this is how it goes in. My patient wanted a very yellow stained look, which is the reason why we've done PFMs with heavy staining. But more importantly, look closely. How beautifully the teeth intercuspate into each other. MIP equals centric relation. The bite is an ideal class 1 when the patient initially came to me with an edge-to-edge bite. Static is one aspect. Look at dynamic. See, in protrusion, there is complete posterior disocclusion. When the patient goes into a left lateral, there is complete posterior disocclusion. Now, imagine this as being an exact copy of my temporaries. Patient goes into a right lateral, again there is uniform posterior disocclusion. If I've done the hard work of getting the occlusion right, on my provisionals, I automatically land up getting that into my finals. So don't treat provisionals like deciduous teeth. Don't treat them in the sense that they are only for a small period of time. Respect them. They will help you in the overall reconstruction process. They add predictability to our work. Very quickly, going on to the last aspect, which is think conservative. I'm going to throw at you a couple of cases which will help you understand how partial bonded restorations can be used for full mouth reconstructions without doing any root canal procedures. I'm a big believer endo only if it is needed. which means endo only if it is a bacterial problem or if the pulp gets exposed as a part of my preparation. Please do not do prophylactic endo. It is only going to increase the budget of the patient. More importantly, it's going to weaken the system, increasing the possibility that your abutment teeth may fracture. So avoid endo, avoid full crown preps. Try preserving as much enamel as possible. Here is a patient who does not smile much because he does not show a lot of teeth. And the reason why he does not show a lot of teeth is because he has dysfunction. He does not have one MIP, but he has multiple positions in which he can bite. This means that he is closing not in the correct mandibular position. Look here, the picture on the left clearly tells you he's biting edge to edge, which means he's brought in his jaw forward. The picture on the right tells you there is attrition that is happening on the anteriors. This picture clearly tells you there is a lot of enamel at the back that has been lost. There is so much dentin that has been exposed. Look at the mandibular teeth that are missing. This patient happened to vertically fracture the molar and the premolar there. Why? Because there was excessive amount of stress and strain on the system. Those two teeth, which are endodontically treated, fractured. Now he was scared that he does not want to lose more teeth, which is where we stepped in for a reconstruction. The process remains the same. Diagnostic impressions with addition silicone. Facebow record. You deprogram with the help of Unwind MD. You register the bite with the help of Bital. Both of these are available on mikdental.in. Once you have all of this, you mount this on a semi-adjustable articulator, do a wax up. Make a putty index of that wax up. With the help of that putty index, you do a test drive. I'm sure you are aware of what the concept of a test drive is. Additive dentistry, show the patient a potential end result. What I love most about test drives is patient can see what I will be able to give the patient. More importantly, a test drive is a brilliant guide for me to do volumetric reduction. Remember, some teeth have more tooth that have been reduced because of attrition, some not as much. All right. So when I'm doing volumetric reduction through a test drive, I only reduce tooth surfaces as much as is needed. Some teeth do not need any reduction because in a sense, nature has already done occlusal reduction for me. Over years, nature has created attrition and reduced that tooth off. And because now I'm working in CR, I automatically have space. This is very common for lower anterior teeth, which are treated very short. Often so much space opens up there, you don't have to do any incisal edge reduction. You have to do minimal posterior occlusal reduction. Remember, the lesser the reduction you do, the lesser the possibility of exposing the pulp. The lesser is the possibility of you needing to do endodontic treatment. So look here, for this patient, I am preparing through the test drive. Now what I want to bring here to your notice is the final preparation line for the anterior teeth. Look closely. My preparation line is not subgingival. It is not equigingival. As a matter of fact, it is far supragingival. I have left my preparation lines in the middle of the tooth. What is the importance of doing supragingival dentistry? Very easy to prepare. No tissue retraction needed. Very easy to make an impression. Technician knows exactly where your margin is. More importantly, your prosthesis finish and flush the preparation margins beautifully. Cement excess cleanup is easy. It is easy for patient to brush and clean that area. It is very easy for me to look at those margins and evaluate it when the patient comes in for a follow-up appointment. And most importantly for this patient, remember, the patient had a very low smile line, which means the underlying unprepared tooth structure will not be visible in the final smile. So why should I prepare my margin? Thinking about conventional dentistry. I am not doing a full coverage crown here. I am doing partial bonded laminate veneers for this patient in the anteriors. Now remember, these are bonded, which means I'm going to use a resin cement to bond them in. I do not need retention or resistance form. this is not going to be luted with GIC. So even if I do not have adequate retention and resistance form, I am not worried for these anterior teeth. More importantly, for posterior teeth, have a look at my preparations. They look obnoxious from a conventional preparation protocol. I have not given 360-degree margins. For the premolars, I have given a buccal margin and I have done occlusal reduction. These are called V-tops or veneer lays. Okay, they have a buccal veneer for aesthetics. They have an occlusal veneer, which is for function. Look at the molars. The molars, I have not even opened the contact. Why? No contact opening means no possibility of food lodgement whatsoever. This is a classic tabletop restoration. What is the advantage of a tabletop restoration? Remember, molars do not contribute in aesthetics. It is all about function. So if I have an occlusal overlay, it's like an occlusal veneer, it's going to restore function whilst being extremely conservative. Why will this tooth need endo? No need for endo. And because there is this white ring of enamel present all around, I will get fantastic bond strength. Remember, laminates don't debond as long as there is enamel. Posterior overlays do not debond as long as there is enamel. And be rest for sure, they do not fracture under function. By themselves, they may be weak. But once you bond them to the underlying tooth, they are superlatively strong. I am more confident today doing this for a Bruxer than doing a PFM or a PFZ or worst case scenario monolithic zirconia, because I am scared that will cause more problems over a period of time than porcelain, which is a replacement for enamel. Here, what am I doing? I am simply replacing the occlusal enamel anatomy. If you're wondering why do I have grooves there, why do I have a buccal groove, a palatal groove, it is not for secondary retention or resistance. It is for orientation. Remember, when I do only a flat occlusal prep, I don't know where does the tabletop or the overlay sit. If I land up mispositioning this even by 1 degree, be rest for sure, once I bond the 6 in, the 7 will not go in. Which is the reason why I make these grooves so that I have orientation in seating. This will make sure that I get my positioning of the veneers perfect. Labially, there are veneers. Occlusally, also there are veneers. This is what I get back from the laboratory. Partial restorations. Okay, look at the molars. You can see those small extensions into the grooves that I have made there. This is how it looks for the mandibular arch. I go into the patient's mouth, I rubber dam, isolate everything. I do a selective etch technique. I go ahead and bond my maxillary anteriors, my maxillary posteriors, my mandibular anteriors, my mandibular posteriors. And this is how it looks post bonding. MIP equal CR in static occlusion. Midlines are not coinciding. Do not worry if the midlines don't coincide as long as your condyles are in the correct position. Do not run behind midline coincision. Why? Because the moment patient loses posterior teeth, remember the entire occlusion will shift. All right, so don't run behind getting the midlines coincident. A midline that is off axis but is straight is not an aesthetic or a functional concern. This is how it looks from the side. Once again, look at the fact that the patient was edge to edge earlier, but we have deprogrammed and we've gotten the patient into an anterior overlap, which means anterior guidance will protect the anatomy of the posterior teeth. I know the question that you're thinking in your head all this time. Patient ko chalta hai kya aise? कि आधा ceramic हो, आधा दांत हो, ऐसे color difference हो. Look here, this is purely occlusal dentistry. Function with aesthetics. Aesthetics has not been compromised. Recognize the fact that this looks like a very happy patient. He is smiling a lot more than what he was smiling before. And yet, recognize the fact that underlying tooth structure is not seen at all. Will this patient complain? Be rest for sure the patient will not, because no patient who gets a full mouth reconstruction done goes out and tells the tells his friends, "Ye dekho, see my new teeth, see my new teeth." They never do this. They're only going to smile wide. And as long as your prosthetic margins are hidden, conservative dentistry is the key to successful rehabilitation. Why? Worst case scenario, something happens to this overlay. Remember, you still have the option of coming back and doing a crown. Once you do a crown, there's no way out. Look here, look at his mandibular 6, the mandibular right 6. That shows the classic tabletop. You can see the porcelain on top and you can see underlying tooth structure below. I would never have guessed a man who does not smile will suddenly start showing a mandibular first molar during smile. I mean, it just shows that when people are happy, they smile wider. The curtain of the lip goes up even more. So you always prepare your teeth more than what the patient shows in their pre-operative smile. You do not want the junction between tooth and porcelain to ever be visible. All right, so let me leave you here with a small mantra that I believe in. Right, this is something that I very strongly urge everyone to start following. Aesthetics, friends, should not have to come at the sacrifice of conservation and optimal function. We can very well give patients aesthetic looking restorations whilst also taking care of biology. Remember, tooth preparations is all about a balance between biologic principle, mechanical principle, and aesthetic. Never the other way around. Biologic principle always comes first. And that's why you have a department called conservative dentistry and endodontics, not the other way round. Conservation of tooth material should be at priority in your head whenever you do full mouth reconstructions. And this even includes patients who are bruxers, patients who have para-function. I know a big question that's in your head: how long do they last? Patients always ask us, lifelong? I say no. Long life. Lifelong to kisi cheez ki guarantee nahi hoti. Do you know how long are you going to live? Then how can I give you guarantee? It has a very, very long life. And over the past 7.5 years that I have been doing tabletop full mouth reconstructions, I have become confident that they survive more than PFM and PFZ based full mouth reconstructions. Imagine doing a patient like this. I know the first thought that comes to your mind is, oh my God, I will have to give this patient Brugzir crowns. I will have to do monolithic zirconia crowns, else the patient will break anything. Please don't do it. When you put something that is so strong into the patient's mouth, the weakest link becomes the human body. If zirconia is so strong, the weakest link in the human system will give. Be rest for sure. I love saying this. Zirconia does not just come with 15 years guarantee. It also comes with a TMD guaranteed. Over a period of time, your patient will develop joint-related problems. Treat these cases in a predictable manner with partial bonded restorations. Imagine doing this with Emax. This patient again did not smile much. Why? Because he does not show a lot of tooth structure when he smiles. What did we do? We went ahead and did the same protocol. We made impressions, we mounted the casts, but here we did a slightly digitalized version of treatment. After having done the digital mounting, we used a virtual articulator to design the wax up and then printed 3D models. What did I do? With these models, I made putty indices. With the putty indices, I did a test drive, and with the test drive, I went ahead and I did my preparations. The top left picture is mandibular test drive. The middle picture is where I have taken a burr and I have sunk it 1.5 millimeters on the buccal, 1 millimeters on the lingual cusps. Why? Because I want as much reduction. In the anteriors as well, I have used my PLV burrs, the porcelain laminate veneer burrs, to make depth grooves. When I remove the test drive, look at the bottom right picture. There are certain areas on the tooth that have the pencil mark, those are the only areas that I now need to reduce further. The rest of the area, nature has already done reduction. So these are my final preparations. Anteriors are all veneer preparations. As you can recognize, all my preparations are supragingival. I don't need to go equigingival. Supragingival means it's very easy for me to make impressions and for me to do bonding. Look at the bottom left picture. For the veneer, for the premolars, again, I have done V-tops. For the molar, I have done an occlusal overlay. I want to bring to your notice a mandibular left molar, the bottom left picture. Look there, that tooth has endo that was already done because that tooth was carious. That tooth is already beginning to have furcation involvement because of gingival recession. Now, what will happen if I give this patient a full crown? Be rest for sure, in the furcal area, there will be more recession. So what did I do? I chose to give this patient what is called as an endo crown. Look at the middle picture now. Look at the occlusal surface of that molar. The endodontically treated access opening is normally what we fill with composites. Here, I have not filled it up at all. I have left it completely open and gone ahead and registered my impression. So now the final prosthesis that comes in has an occlusal veneer and a small umbrella-like extension in porcelain. And I go ahead and I bond that directly onto the tooth structure. Endo crowns work brilliantly for posterior molars, which are endodontically treated. Please don't do these for premolars, do them for molars. They work fantastically well. Right? Moving ahead, these are my final preps for the maxillary arch. This is just a picture showing you how thin my temporaries are, which means I have done barely any occlusal reduction. The only reduction per se that I have done is rounding everything off. Why? Because porcelain does not like anything that is sharp in the underlying substructure. So smoothing everything, rounding everything is all I have done. Some peripheral reduction to get my anterior guidance correct. And this is how the laboratory sends the prosthesis back. Look at all those posterior palatal surfaces. These are classic tabletops where only and only the occlusal portion is covered. Look at how thin they are. Average, we say between a 1 to a 1.5 millimeters is more than enough. Now remember, just this much reduction done, you will never expose the pulp, especially in a bruxer, because remember, in bruxers, you have so much tertiary dentin, the pulp has actually receded away. So do not fear any pulpal exposure in these patients. We go ahead and we bond them in. All the maxillary, all the mandibulars. And guess what? You remember his smile from before. And once we've bonded our prosthesis in, this is a completely new human being. We've not just changed his smile, but be rest for sure, we've changed his life, his attitude, and his approach towards the dental fraternity. Here again, see a small aesthetic error at my end. Look at the 6. The patient is smiling so wide suddenly that he's showing the buccal portion of the 6. I should have ideally covered that. But remember, patients who see a gratifying change in the front do not care about what is happening at the back. This is not just improving aesthetics, but more importantly, improving function and the quality of your patient's life. Remember, friends, the very word dentistry is telling us a very important thing. It's telling us, dentist, try. When I first heard about partial bonded restorations, I would not believe it. And I know a lot of you out there are of the same opinion. I was as well, until I heard the speaker tell me, my friend, you cannot learn swimming by watching someone else swim. You will have to dive in. Go back to your practices, start doing partial bonded restorations. Imagine telling your patient, I will not do a full crown, I will do a half crown, but I will charge you more. How does that even make logic? You're not doing a full crown, you're doing a half crown, but you would charge me more. Yes, It is because I am going to preserve your own enamel. This is how I explain it to my patients. I tell my patients, do you know what an appendix is? And everyone's like, of course I know what an appendix is. What do you think about it? Fantastic. Now imagine if someday you have an appendix related problem and the surgeon has to remove the appendix. They'll tell you, we have two options. We can do open surgery. It will cost you X rupees. We can do laparoscopic surgery. It will cost you 2x rupees. Which one will you choose? You will choose laparoscopic. Why? Because it is more conservative. Biology will have more price than porcelain. My patients love the fact that I am conserving their tooth structure. How many patients have told you after a crown preparation, Doctor साहब कुछ बचा ही नहीं दांत पे, ये टूट नहीं जाएगा क्या? And you're thinking in your head, I hope this does not break. Remember, most crown preps involve peripheral reduction of an endodontically treated tooth which has a central hole. Bacha kya hai? You just have a ring of dentin. That dentin can easily succumb. Think conservative, friends, not just full mouth reconstructions. Do endodontic treatment, give a partial bonded restoration. Your lab cost is less than your zirconia cost. Yes, EMAX often costs you less than zirconia restorations. So your costing does not change. All you need to do is invest a little extra into your resin bonding. You may have to do rubber dam isolation, but in these COVID times where infection is a big concern, I am certain rubber dam is going to become a standardized protocol. So please invest time, effort, and money into taking care of yourself, your family, your patients, and your loved ones by isolating and working under rubber dam. I'm a big believer, friends, that success does not come by accident. It is hard work, it is perseverance, it is learning, it is studying, it is sacrifice, and most of all, it is the love of what you are doing. We have been forced to stay away from our practices. We have been forced to not do what we love doing. It's for a few more days. I love to say this, Hati nikal gaya hai, bas pooch baki hai. We have been superheroes, friends, by staying at home. Please let us continue supporting the fraternity. My friends, I am Moez Khakiani. You can follow me on Facebook, on Instagram, on YouTube. Here I am sharing with you my personal contact. The best way to connect with me is on WhatsApp. If you have questions that I have not been able to answer on this platform, feel free to connect with me here and I shall try my level best to do justice to the time that we've spent together. I have been very fortunate, friends, to have scripted a book which is called Clinical Fixed Prosthodontics. It is in its second edition. We have two versions. We have a starter volume, we have a master volume. The starter volume, friends, is all about crown and bridge dentistry, which is for the beginner in you. We have a master volume which has full mouth reconstructions, details of a lot of protocols that I've mentioned here. A lot more cases are in there. We have in that book implant supported restorations, we have porcelain veneers, we have partial bonded restorations, we have multidisciplinary dentistry. So please, my strongest request would be log on to mikdental.in, pre-book it once we have our services of couriers and printing resumed. We promise that we shall send them across through to you. As I come to a close to the explanatory part of this webinar, a big shout out and a big thank you to Dental Reach and for everyone behind for making this possible. I once again request all of you all to support us in the campaign that I title #NoErota, No Aerosol. Friends, if you want the PDF of this webinar, please log on to the link that has been provided to you. There you will be able to get the PDF. Remember, the PDF is password protected. So please, when asked for a password in capital letters, put in MIK, MIK, and the PDF is all yours. With this, friends, I conclude the explanatory part of this webinar. I hereby leave this session open for question and answers. Thank you so very much, everyone involved. I have had an absolutely amazing time sharing with you guys. Right, over to Dental Reach. I am ready to answer questions, friends.
Hello, doctor. Hello, doctor. Can you hear me? Yeah. Can you hear me, please? It, it's been a very good session by Dr. Moez, and it was a really informative session for you, for all our audience related to dental reach. We wholeheartedly thank Dr. Moez for posting such a very optimistic as well as say enlightening lecture regarding the restoration of these teeth and to preserve the crown as much as possible. That's what Dr. Moyes has suggested us. So we need to follow, and I'm very thankful for Dr. Moyes to posing such a challenging thing in this current scenario where people are very much dreaming about investing on, say, PFMs as well as, say, full mouth zirconia crowns, and you know, without realizing the fact what Dr. Moyes prominently said that we don't know where the forces are landing up. That's what Dr. Moyes means. Okay, so doctor will log on to the questions. Uh, we we are getting a lot of questions now. So to start off with, I will just ask you, I mean, to do some enlightenment on deprogramming devices, as many doctors are asking how many days to will it work, or weeks or months, and will the deprogramming device completely say uh, completely deprograms the mandible, and another doctor, he says that uh, will the deprogramming the use of deprogramming will lead to supra eruption of the posterior teeth, and how to manage it? Please answer that, sir. Doctor, please, doctor, please, can you on your mic? Hello. Yeah, yeah. Yeah, doctor. Now, another question is that how uh, when does condyle goes upwards and backwards with deprogrammer so that the lower anterior also follow the same direction? That means it shouldn't be therefore be uh, you know he is talking about the flat plane guidance. I will one more time repeat the questions. When condyle goes upwards and backwards with deprogrammer, so will the lower anteriors also follow the same direction. Shouldn't therefore be a ramp in a deprogrammer to allow the glide?
Understand here that the condyle follows a different arc, the lower incisor follows a completely different arc. Right? Remember, the mandible is a class 3 lever. Right? The fulcrum is here, the force is here, the effort's here, which means as the condyle goes upwards, just try to trace my thumb, the condyle is going upwards, the lower incisor is not going upwards. The lower incisor goes downward and backward because the fulcrum is not here. The fulcrum becomes a terminal molar tooth.
Exactly.
Because the molar becomes the fulcrum, the entire lever principle changes. So remember, the condyle goes up and the lower incisor comes downward and backward, which means it brings the lower incisor horizontally backward and vertically downward. I hope I've answered that question.
Yeah, doctor. And there's another question by our renowned speaker, Dr. PC Jacob. In what percentage of population do CR and MIP coincide?
Jacob sir, thank you for attending for this question. Love you for what you do, and thoroughly enjoyed your post and pour session. Thank you for that. So, Jacob sir, it is routinely said that more than 90% of the population has a CR-MIP discrepancy. Typically, a discrepancy that is less than 1.5 of a millimeter is considered normal. Having said that, when we say normal in the years that research was done may not be normal as applicable today, because what has changed is the stress factors and the biting habits. The earlier human beings would grind their teeth down very quickly at a very early age because of the fibrous content of the food. Today's patients do not grind the teeth down as easily because of the food habits, but because of the increased stress levels that we have in our lives. Interference without stress in a very relaxed human being does not cause a problem. But when that same interference steps into a patient who has now become stressed, may start manifesting symptoms. Signs of breakdown are very common. We see attrition, we see abfraction, we see fractures, sensitivity. A lot of patients don't come to us until it reaches a phase of irreversible damage, which is where the problem of the interference comes in. If we see signs of breakdown and we stall the process by correcting the bite, it will not progress further. It is just like what we do in orthodontics, which is called as interceptive orthodontics. It's not full-fledged ortho, but it is to prevent a full-blown ortho later. So interceptive occlusal correction will help these patients not become full mouth rehabilitation patients in the years to come. So although MIP and CR do not coincide for more than 90% of the human population, our patients are the ones who have manifested signs from the presence of these interferences. I hope I have done justice to answering your question, Jacob sir.
Yeah, doctor. So there's another question saying that customization of anterior guidance for every patient. How do you do that?
There is no fast or fixed formula for this. This has to be done individually in the patient's mouth, because every individual is said to have a different envelope of function or an envelope around which the mandibular movement occurs. So there is a sequence of 7 steps that you need to follow when you are setting the correct anterior guidance for the patient. This is the reason why I always do this on acrylic temporaries first, because on acrylic temporaries, remember, I can trim down and reduce the height. Or if I feel 4 out of 6 anteriors are touching, the other 2 are not touching, I can simply add some flowable composite there and get the anterior guidance customized. Now I make an alginate impression of it and send it to the technician. The technician makes putty indices, cuts the putty indices in different planes, and uses that to build up the porcelain, which means the effort that I have put in the patient mouth in the form of composite can very easily be copied by the technician in porcelain. He or she just can make it look that much more better. So my job of customization has made sure that my final porcelain crowns not just look and feel better, but more importantly, they even function better. Right.
Yes, doctor. There's another question saying that can we get more than 1 RCP points? If yes, what can be done?
Yes, absolutely. No 2 human beings are the same, which means it's not compulsory for you to get an RCP only on a 7. Your RCP could be on a 5 and a 7 together. Your RCP could be on this 7 and this 6 together. All right. Different individuals will have different RCPs. Now, it does not matter which tooth has the RCP. What matters is at RCP, what is the position of the anterior teeth? If the anterior teeth are in a correct overlap relation, and if you feel you can get the correct anterior guidance and the correct incisal edge length, you don't have to open the bite any further. But imagine if at RCP you realize your anterior teeth are not in the position you desire, you don't have an option but to open the bite. The simple answer here is open the bite the least that is needed to get the anterior guidance in position, which means, in my opinion, I always determine the patient's vertical dimension objectively, not subjectively, which means not in the patient's mouth, but always on the articulator. Because remember, on the articulator, there is no periodontal ligament. So tooth to tooth contact will always be in a static RCP position. Right.
Doctor, which horseshoe shape articulating paper do you use or do you recommend?
So as much as I love to use a thinner 12 micron paper or even an 8 micron paper, I love to use troll foil, TROLLFOIL. Troll foil, however, it comes only in seconds. It's 8 microns. So for a horseshoe shaped articulating paper, I would suggest you to use from Bausch 40 microns. It is called ARTICHEK, ARTICHEK. ARTICHEK will be available in a blue color as well as a red color. So you use blue for your static contacts, you change to a red, and then you check for your excursive contacts. Right.
Okay. Okay. Doctor, there's another question talking about bruxism, and he says the doctor means that bruxism is psychological thing. So after FMR therapy, again the patient will land up doing bruxism with the crowns whatever it has been delivered. So how do you tackle this?
Absolutely correct, my friend. It is often said that bruxism is centrally mediated, which means it's coming from the brain. All right. So a patient who is a bruxer may continue to brux even if you have done a beautiful full mouth reconstruction. All right. Now, it is commonly said that bruxism is a parafunctional habit that happens at night time because during the day the brain is awake. It's protecting. So what I do is, if I have done a full mouth reconstruction for a bruxer, I will compulsorily have the patient wear a full arch acrylic splint that has mutually protected occlusion designed on it. It's called as a permissive splint. If you want more details on the permissive splint, again, I have shared off the same on YouTube, a specific video that shows you the design of a permissive splint that I would want to give a patient who is a bruxer. Now, what does a permissive splint do? It acts like the shock absorber. The permissive splint is simply made of acrylic. So when porcelain contacts porcelain and the patient is, rather porcelain contacts acrylic and the patient is bruxing, the acrylic will have wear facets that will generate on it, but porcelain will not touch porcelain. I won't give this patient, and I repeat myself, I won't give this patient a soft night guard. Soft night guard will cause the patient to brux even more. If I put a chewing gum in your mouth, what do? You will clench down and brux more on it, which is the reason why soft night guards always perforate at the back. I want a hard acrylic splint because it acts like a shock absorber. It does not allow the tooth or the periodontal ligament to take the brunt of the occlusal force. So treat a bruxer
Okay.
and then your bruxer wears a permissive splint. And tell the bruxer you have to wear the splint before treatment. Don't say this after treatment. They will tell you, "Pehle bata dete, hum karwate hi nahi." You don't want such a situation to arise. All right.
Okay. Yeah, yeah, doctor. There's another question saying that how do you reconstruct for the opposing arch when there is no anterior guidance and the teeth are missing?
Remember, if teeth are missing, you are not going to leave them like that. Your patient is not going to come for an arch construction without anterior teeth on the lower front. So you will be reconstructing teeth. Now you have two options. Either you may give the patient a bridge here, or you will do implants and give fixed crowns on top of it. So what I would suggest is go ahead and do this, the lower anterior. Let's say example, the lower anterior is missing. Go ahead and do your bridge in acrylic. Now give your deprogrammer on the upper arch with the lower acrylic bridge, giving you the anterior stop. And then proceed with preparations of all the other teeth. This way you can give your patient a reconstruction whilst deprogramming. Now, if you don't have the option of a bridge, if you don't have the option of implants, the only way out is to deprogram with a full arch splint. The same full arch splint design that the patient is supposed to use after the reconstruction as well. Again, YouTube video there will give you an answer for what is this design that I'm talking about, friends.
Okay, doctor, yes, do you do this, the final processes with splint or individual crowns? Or wherever it is indicated, where the individual crowns are indicated, or where do you suggest splinted crowns are indicated?
The only time I would splint is if I'm concerned about a tooth being mobile. Because there are times when, let's say, a premolar has some recession and you know that tooth is a little mobile and it may not self-strengthen itself. Because remember, bone once gone is gone. All right. So if a tooth is slightly mobile, I would want to splint it with an adjacent strong tooth to make sure that I have splinted them and distributed the functional load. There are times when I splint anterior teeth. Imagine a patient who's a bruxer and loves to do this. That's horizontal chewing pattern. When I've given this patient an anterior overbite, I have locked the mandible. This is called restriction in the envelope of function. This patient will now push the teeth away to regain that freedom of movement. And if the anteriors are now single, they will start flaring away. Patient will be like, Dr. Saab, abhi ye gaps khul rahe jo pehle nahi the. These are patients where I would want to splint anterior teeth. Having said that, whenever possible, I will always keep posterior teeth separate, keep them individual. Every individual tooth has its own periodontal ligament, has its own identity. Don't take away by splinting them together. Worst case scenario, you do a bridge of 40 that are joined together. Ek molar ke andar agar problem hua, you will have to remove that entire bridge to work on that. All right, so you'd rather give every individual tooth, because if something were to go wrong, you can only treat that one tooth and get away with the problem. Right.
Right, doctor. There is another question saying that material of choice for tabletops and luting material you use.
When it comes to material of choice for tabletops, fortunately or unfortunately, there is no choice. It has to be lithium disilicate, that is Emax. Right. Bonding is done with the help of a dual cure resin cement. I prefer to use U200. That's the yellow color clicker that comes in a barrel dispenser from the company 3M. Right.
Okay, right. There's another question saying that where do you place retentive grooves in individual crowns, buccolingual or mesodistal in complete crowns? Where do you place retentive grooves in individual crowns, buccolingual or mesodistal in complete crowns?
Okay, so what I typically do is if I'm doing a full crown, if it's a single crown, I will always give a mesial or a distal groove. If I'm doing a bridge preparation, I will give a buccal or a lingual groove. This is to do with the direction of forces in which the teeth, the prosthesis tends to topple over.
Okay, doctor, there is a we will just finish the session in 10 minutes. We will take a few more questions regarding the endocrown. Somebody is asking which material is will be preferring for endocrown.
The same answer, my friend.
Material
When
of
you're
choice for
talking about
endocrown.
an endocrown, this is again a partial bonded restoration, which means the only and only material of choice has to be lithium disilicate, because it is the only material that can be etched. And for bonding, etching is a necessity. Right.
Yeah, and one more doctor is requesting you to do a session on partial bonded restoration. It's up to you, and let's hope we see that too.
Dr. Samuel, Dr. Nupur, I hope you are taking note.
Okay, now the last one will be this one. Indirect composite tabletops can be used, or it is only porcelain to be used.
Indirect composite tabletops, in my opinion, are going to become a very important treatment modality. I'm sorry, I'm getting a lot of text messages here which say I'm not audible. Am I audible? Am I not audible, please?
Yeah, you are definitely audible, but there is little issues, doctor.
Am I audible now?
Yes, you are.
I am audible, right?
For me, you are. Yeah.
Yeah,
For
because
me, you are audible.
I
You
see,
need to just.
I see a lot of people
Yeah.
telling me no audio, no audio, no audio, no audio. Mic is still not
No,
working.
the audio, no problem. No problem. We can just answer their questions by sending them messages or even
Okay.
via mail.
They are now telling me I'm
Not an
audible. I'm audible now. Okay, I'm glad I'm finally audible. Okay. Please repeat the first question answer. Okay, I'll come to that. No problem. No problem. Okay, so we were talking, friends, about tabletop direct composite full mouth reconstructions. Now, I have done attempted 3 cases. I have successfully completed 1. We're still trying to figure out which is the best way to do direct composite restorations. With the advent in CAD/CAM technology, I believe that is still a huge possibility in the times of these coronavirus-related economic crisis situations, where patients who need full mouth reconstructions but cannot afford them today. What I would urge you to do is do anterior porcelains and do posterior composite tabletops. Why is it that I insist on anterior porcelain? Because remember, your anterior guidance will protect your posterior composites. So if your anterior composites wear off, your posteriors will wear off even faster. So do your anteriors in porcelains for now, do posterior tabletops in composites. We normally do this by copying the wax up. So we make putty indices of the wax up and then we transfer it into the patient's mouth. Not a very easy task. We're still getting to understand that. I have included a massive section on this in my book, that is Clinical Fixed Prosthodontics, how to do full mouth reconstructions in composites. I am hoping you guys can get a grab of the book and gain more knowledge and understanding of that concept. But yes, I am a big believer that a concept in that regard is here to stay for the future.
Yeah, doctor, last 2 questions here. When do you do Broderick plane analysis? Broderick plane analysis and any alternative to that?
All right, so I would do a Broderick plane analysis if I am a PG student. As simple as that. I find very little clinical significance to the same. I would always believe that my patient's mouth is the best articulator. And if I can get my curve relatively flat, right? Which means if I extract a third molar, if I were to reduce my second molar adequately, I'm never concerned about a very steep curve of steep. And if I'm not concerned about the curve of SPE being that steep. A Broderick's analyzer is something that I had used only to write a couple of articles. After that, I have never ever used it. Right.
Okay, doctor. The last question, and it is it little tricky one.
Okay.
It will bring you a perfect smile on your face.
All right.
How do you convince lab technician for this kind of processes?
You are so right in saying that, right? And you built it up so beautifully for me. All right. How do I convince my lab technicians? Let me tell you, lab technicians, to me, are family members. Our relation with lab technicians, unfortunately, is more of a need-based one, which should not be. I mean, believe me, those guys are very skilled. They are way more hardworking than we are, because they sit in a furnace, literally in a furnace in their laboratories, and are answering to all our questions. मैं हमेशा ये बोलता हूँ, ताली दो हाथ से बजती है.
I will.
All right. Yeah.
I will just put it in a simple way. I will just put it in a simple way. Lab technicians are the people, they, like all the boys and girls, wear a proper clothes from a designer. If you like a designer, you will never leave them. That is how the dental labs are. So we have a good respect for the dental labs as well. And I wholeheartedly thank Dr. Moez for wonderful lecturing and his attitude, overwhelming attitude, and very positive, a strong message that what he gave us, that is, whenever time possible, it is the time to change. It is the time to think out of the box, and the out of the box thinking comes from experience, with lot of cases, and simultaneously with guidance from the mentors what we have. So we have our mentor here for today, Dr. Moez, and we thank you from the dental reach point of view, and you have been a great aspect for us. So please kindly educate our audience with much more innovative cases and videos and lectures, so that we learn together.
Absolutely.
Okay. Thank you, doctor.
Absolutely.
Thank you very much.
Thank you so much, Dental Reach. Thank you so very much, Dr. Samuel, Dr. Nupur, and everyone who attended this. Once again, remember, hashtag no aerotor, no aerosol. Let's stay home. Let's stay safe. Let's take care of everyone in our families. Until we meet again, friends, wish all of you all a lovely time ahead. Take care. Bye-bye.
Thank you, doctor.
Thank you. Thank you.